Good morning. I call the Health and Human Services Finance and Policy Committee to order. I will just note for the public that we do not yet have a quorum. I will announce that when we do, and Senator Mann is joining us via Zoom. We are going to start with Senate File 1059, Senator Marty, who is also on Zoom. You may begin.
Thank you, Madam Chair and members of the committee. I very much appreciate the chance to present Senate File 1059 to you. This is a bill, we're calling it patient-centered care, and it would take, the simple thing it would do is would take our public programs, Medicaid and Minnesota Care, and replace the current managed care delivery system with one where we pay clinics, providers of all kinds, doctors, hospitals, directly for the care they provide to patients, eliminating the use of the health plans as a middleman. State would not renew contracts with the HMOs or IHPs for either Minnesota Care or Medicaid. And on top of the payments for those direct services, would also pay primary care providers a small monthly fee for coordinating care. Patients would be encouraged to choose a primary care provider who would then help them navigate the healthcare system. It would also, the bill would also call for collaborating with community clinics to do some outreach to people who are not receiving care, many of whom, because of challenges such as mental illness and homelessness and so on, do not have access to care, even though they would be qualified and are qualified for Medicaid. So in the rural counties, there are 33 now that use county-based purchasing. We would continue to use them. They, in effect, would be implementing, instead of DHS, which would be running the program elsewhere, would be done by the county-based programs in the other counties, and state and counties would be able to continue to choose whether to be part of a county-based purchaser or leave it up to the state. Why would I suggest we do this? First of all, the current system where we pay managed care organizations to pay providers is a costly, unnecessary, and I can call it incredibly bureaucratic step. Eliminating the middleman in this kind of process can save a lot of money. Connecticut is one of very few states that has dropped their Medicaid managed care, and they have reported, they dropped it in, I think it was 2012 or 2013, and they've had their costs, which were rising way out of control, have come way down. They've got reports that they're providing much better care to people, and people in the program appreciate it much more, and I think the providers have indicated the same thing as well. The scope of the savings in this could be incredible. There was an article in the business section of the Star Tribune 2 years ago, talked about how the Minnesota health plans using our publicly funded programs made over 2/3 of $1 billion. I think it was 675 million in earnings. They're not profits because they're nonprofits. In earnings in the year before, that's 2/3 of $1 billion on our public programs. Second reason I do it, not just for cost. The second reason is that they often interfere with care, denying treatment to MA patients, even though we're paying for the care. They do this through prior authorization, limits of networks, other things like that. I can give more examples if you're interested in that. Then next is they have limited networks. And again, that has caused real problem, especially given the fact we've had churning and turnover of plans. A number of years ago, UCare was largely dropped from the Medicaid program when Medica gained a larger contract. A year later, Medica withdrew from the market, causing, I think it was 300,000 people have to switch coverage again. This kind of churning is all addressed by eliminating this. For care coordination payments, and this is very important because I think one of the things that's lacking, including in the managed care system we have, is good care coordination for patients. And I will have in a minute advanced practice nurse who will testify in speaking to some of the issues of care coordination. But what we want to make sure is that we have a system out there that makes sense, which is generally the provider that makes sense to do the care coordination. We'd be providing from some of the savings from the removal of managed care we'd be using to coordinate payments. A couple other little provisions in the bill. One, we would be directing Commissioner of Human Services with available funds from some of the savings to do outreach to people who don't get care otherwise, whether it's social workers or healthcare navigators, a term we use in a different way right now. They're insurance navigators now, but we need people who can help folks navigate their healthcare. I think this would be a significant step in removing health inequities And this would take, again, Minnesota's Medicaid and Minnesota Care population is about a fifth of the population of Minnesota. It's over 1 million people. I think there's a wide recognition among providers, among advocates for the people using the programs and so on, that the current system is not serving it. And I'll point in the packets, I think there's a letter from American Cancer Society. They use the term patient navigators, which we haven't defined in statute. I told them I'm very open to using that term as well, but for care coordination. And they talk about how important this is for cancer patients. I think that's true for every kind of patient as well. And our current system just isn't doing it. And I'll go through the bill very quickly before turning over to Ms. Batalden, if that's okay, Madam Chair.
Absolutely. Go ahead.
Good. Okay. The bill, the first section of the bill, it's fairly simple. It's just saying that the patient-centered care program is created and it would pay healthcare providers directly for all the program services for Medicaid enrollees and Minnesota Care enrollees. In the counties, paragraph B, in the counties that use county-based purchasing, they would continue to do that, or they and others could join or switch plans or whatever. But the counties would be running the programs, they'd be administering it and paying the providers unless they chose to turn it over to DHS. And frankly, the reason they're in existence is to do it. Payments to providers would be paid directly. They'd be paid to the specific clinic, to the specific provider, not to a healthcare system, but they'd be paid to the provider. It's truly a payment for the work you're doing, which is the way the rest of our economy works, and it's far more efficient. I will mention that paragraph C points out we would not renew managed care contracts when they expire. Subdivision 3 on line 10 of page 2. Care coordination would be small providing payments to that. And we would just simply be saying we want to start moving forward. Primary care is one of the best ways to the place that's appropriate to coordinate care for people. And then the subdivision 4 is simply the community outreach, and that's with any savings we have from this, we could use paying some of the community health clinics to hire more community health workers to do more work like this and more outreach in the community. Subdivision 5, among the duties for the commissioner would be to establish a statewide 24/7 nurse hotline. That's an urgent need. I have had that in the years I've been in a health plan. Health plans generally do that. We want to make sure the state does it as well. And then section 2 of the bill is basically largely conforming stuff. It would be changing, the subdivision 1 would be changing our healthcare homes thing. So basically, any of these primary care providers, you don't have to jump through all the hoops that were created. When former Senator Berglund many years ago created the healthcare homes, I remember her speaking a few years ago about how she was horrified at how complex they had made the program. So a lot of providers didn't choose to do it because there's so many hoops to jump through. It wasn't giving them extra funding, it was costing them more. And finally, so that's that section. The end of it, the repealer bill would be just repealing the integrated health partnerships, because that would be conforming language as well. With that, I'd be happy to stand for questions, but perhaps if you're willing to have Sonia Batalden, my presenter, go now, I'd appreciate that.
Very good. Yes, we will move to testimony. I will also just note that we do now have quorum as a committee. So our first testifier, Sonia Batalden, please introduce yourself, unmute yourself, and proceed with your testimony.
Hi, thank you, Senator Marty, for your work on this bill and the invitation to share my experience. And thank you, Madam Chair and the committee, for taking time to listen to my experience this morning. My name is Sonia Batalden, and I'm a nurse midwife who's been working in the community for the last 30 years in community health. Most of my patients are on Medicaid or uninsured and in the process of applying. As a clinician in this situation, by default, I've had to learn the dance of access to insurance coverage. And I'd like to share my experience of PMAP plans as I see it play out in people's lives. In short, there's a lot of confusion. After applying for Medicaid coverage, patients finally receive their Medicaid approval, only to receive another packet the following month asking them to choose a PMAP plan. Many patients bring this mail in the envelope to their visit, confused about what this list of plans means. For non-English speakers, this letter is often not even in their language. If they don't choose a plan, they are assigned to a PMAP and new cards arrive the following month or so. People wonder, am I insured? Was I insured? What should I do with these different cards? While information on various PMAP plans exists online, few people have the bandwidth to absorb these details. PMAP plan assignments are usually by default, not by informed choice. Plans change from year to year as various counties contract with different PMAPs at different percentages of the market. People are often changed from one plan to another, creating more confusion. The change of plans has significant impact on people's lives and wellness. Here are some examples and patient stories that I have seen. I may be seeing my neurologist for my seizure disorder. My PMAP changes, and now my neurologist doesn't accept my plan. While seeking a new neurologist, I have a gap in seizure medication and misplanned follow-up for imaging. The wait for a new neurologist in a new clinic is 6 to 9 months. Meanwhile, I end up in the ED with seizures. Or I plan to give birth at a hospital only to learn that my PMAP does not cover prenatal or postpartum care with the doctors from this hospital. I cannot go to their clinics to receive continuity of care for my high-risk pregnancy or birth. I drop out of care or receive patchwork care in different care systems due to my PMAP coverage. This happened countless times with one of our major hospitals in St. Paul and one of our major primary healthcare systems in recent years. Or I have monthly Sublocade injections for substance use treatment. When my PMAP changes in the new year, unbeknownst to me, my injection is no longer covered by my new plan. It requires a new set of prior authorizations to access or is not approved. This delay or disrupted treatment sets me back in my recovery journey. Or I need a breast pump or other medical equipment. Different PMAPs cover different types of breast pumps through different sources. As PMAPs change, the client and the provider are left to navigate how to get different equipment they need. Each PMAP has different coverage and pathways for doing this. We take up considerable clinic staff time researching, updating, faxing, calling, and clarifying how to get things like breast pumps, blood pressure cuffs, walkers, support hose, and many other things for clients. Pharmacy benefits and preferred tier medications vary between plans. As people are shuffled from plan to plan, this impacts their diabetes or other chronic disease state medications. It creates gaps in access to important medications and consumes countless hours of staff completing prior authorizations that are individualized for each PMAP, some through this specialty pharmacy or some through a different one. In addition, some medicines vary if they are on the pharmacy benefit or the medical benefit, depending on the PMAP, and require access in a variety of different ways. The maze of this can be mind-numbing. In a community clinic, if we could take all of the time we spend assisting patients in navigating their PMAP benefits, completing prior authorizations customized for each company, and resubmitting bills to changing coverage, we could place so much more energy on navigating health and wellness for our clients. As an example, we currently have 2 full-time staff who spend most of their time navigating prior authorization on PMAPs in our community clinic to support 10 providers. A recent Kaiser Family Foundation study that just came out at the end of February of this year found that PMAPs had a 12.5 denial rate that is twice as high as Medicare. PMAPs often hold up wellness incentives or health navigation services they provide as a valuable bonus or impact. I'll be honest. Let's look at Pap smear incentives for an example. In my tens of thousands of clinic visits over the years, I can count on one hand the number of people who came in with an incentive form in their hand for their Pap from their PMAP, or saying that they came because their insurance reached out to them. And don't get me wrong, I love giving patients incentives and prizes. I try to leverage these all the time. But on the other hand, the number of patients that have come to care because one of our clinic team members or a public health nurse talked to them in the clinic or in the community and helped them schedule a visit is nearly a daily experience. It is the magic of that relationality of the care team that makes the difference. From what I see in practice, the plan-based navigators are focused on helping the client navigate their benefits, which is necessary because they are very complicated. Increasingly, many of the incentives and plan benefits are only available through an app. The majority of my patients do not navigate the app and incentives unless our clinic staff take the time to help them do this. As proposed in Senator Marty's bill, if we could take some of the repurposed dollars from PMAP spending and direct them to the boots on the ground community health workers and health navigators in the clinic, Minnesotans could receive much more valuable support at the point of care. Every day, I watch our community health workers creatively meet people where they are at and help them take down barriers to wellness in their lives, navigating transportation, housing, food resources, personal safety, and health literacy. This type of work is invaluable, but the need for this type of work in the clinic and the community always vastly surpasses the resources that we have. If even a portion of the dollars we currently spend in PMAP administration and profits in Minnesota could be redirected, it would have a large impact through clinic-based community health workers. In short, simplifying our Medicaid coverage to one statewide program without PMAP involvement would improve and streamline our healthcare provision in Minnesota, removing countless headaches for patients and healthcare providers. One Medicaid product would better utilize our government healthcare dollars to drive better healthcare outcomes and wellness in our state. Thank you for your time.
Thank you for your testimony. Next, we will hear from Chelsea Olson, and after that, Joel Wiklund. Ms. Olson, when you are ready, please introduce yourself and proceed.
Hi, my name is Chelsea Olson with the Minnesota Council of Health Plans, the trade association of the nonprofit health plans, which is Blue Cross and Blue Shield of Minnesota, Health Partners, Medica, Sanford Health Plan, and UCare. Thank you for the opportunity to testify today with our opposition to Senate File 1059, which would end the state's managed care program and the partnership between DHS and our nonprofit members to support roughly 1 million low-income Minnesotans with access to needed healthcare services. First, I want to draw to your attention that as directed by the legislature last year, DHS is currently working with a vendor to study and develop 5 alternative model options to the MCO managed care model, including proposals similar to this plan. We look forward to the results of that study that are due to the legislature by January 15th, 2026. And in the meantime, moving forward with this proposal seems premature. The most important question that needs to be answered on this proposal is, will the lives of the 1 million Minnesotans currently enrolled in managed care be improved if it's eliminated? We contend that the answer is a firm no. The managed care model provides several significant benefits to the state, but most importantly, it improves health access and outcomes for Minnesotans. Care coordination, as currently offered by MCOs, means serving the whole person, not just paying claims. Joel Wiklund with UCare will go into some of these specifics in his testimony, but it's important to note that building health equity and addressing social determinants of health is currently woven throughout all aspects of care coordination. And MCOs have worked together with DHS to integrate high-quality health equity requirements into the latest round of MCO contracts. Beyond high-value services, MCOs were created to bring financial stability to the state by taking on the financial risk. MCOs are subject to a 5% withhold to ensure performance and quality metrics are met, with an additional 3% withheld purely as the state fiscal year payment delay. This combined 8% totals more than $1.5 billion. This bill does not address how the state would incorporate performance metrics to ensure high-quality care, or how the existing funding shift would be addressed. Finally, MCOs are regularly audited for financial accountability, and each MCO has a special investigations unit to conduct investigations of potential fraud, waste, and abuse. And state statute caps MCO administrative expenses at 6.6% to ensure state funds are being used for health care. All the enhanced services and the successful public-private collaboration that exists today to support Minnesotans through managed care would cease to exist under this bill. Instead of eliminating the service, Minnesota's exclusively nonprofit managed care model should serve as a successful model for other states to emulate. Thank you.
Thank you for your testimony. Next, we will hear from Joel Wiklund. Please introduce yourself and proceed.
Thank you, Madam Chair, members of the committee. My name is Joel Wiklund. I'm the Vice President of Public Affairs at UCare. UCare is a nonprofit health plan serving approximately 600,000 members in Minnesota. Our members, currently we have 2/3 of our members are enrolled in Medicaid, Minnesota Care, Medicare, Medicaid integrated models that we have for seniors and people with disabilities. And I wanted to give you an opportunity to just talk a little bit about some of the concerns that we have with this bill. I want to share why retaining managed care, particularly our nonprofit, community-focused approach, provides vital benefits for Minnesotans. Let me start by acknowledging the concerns raised by Senator Marty and others. Accountability for taxpayer dollars and fair funding for providers is absolutely vital. But I urge you to consider that Medicaid managed care, as we've built it and reformed it in Minnesota, is not the problem. It is actually part of the solution. First, on the issue of the middleman and the money reaching providers. Today's managed care plans operate under strict requirements about how much of every premium dollar must be spent on actual health care. An independent federal audit confirmed that Minnesota plans are meeting that mark, and the vast majority of the Medicaid funds are supporting patient services. All of Minnesota Medicaid plans are nonprofit. At UCare, this means that there are no shareholders pocketing profits, which allows us to reinvest in our members and our communities to improve health care and health outcomes. Managed care financial reporting from Medicaid is transparent, and it is closely watched by the Department of Human Services, the Department of Health, the Department of Commerce, the Office of Legislative Auditor, and the Federal Office of Inspector General. Medicaid managed care plans are required to provide detailed data and financial reporting to the state on a quarterly and annual basis. Managed care administrative expenses are limited at 6.6% of total DHS payments, and these are significant reforms that the legislature has passed over the past decade. Second, managed care provides flexibility and services beyond the Medicaid benefit set to partner with the community. UCare started as a Medicaid plan in 1984 and has invested in our members to keep them healthy. We don't just wait for our members to get sick and need care. We are supporting our members through numerous community initiatives, such as Twin Cities Mobile Market and 25 sites to help make sure that healthy foods are available to our food insecure members. This means our members can access healthier foods and manage chronic conditions, reducing the need for more costly medical care. We provide car seats to keep infants safe. We provide fitness classes and grocery discounts to keep our members and help them to stay well. Our staff is out in the community to directly connect with our members. We reach out proactively to our members who are at higher risk of hospitalization. This means that our staff is going out right to where our members are at, whether they be at adult day centers, public housing, or whatever the case may be, to try to better understand what's going on and what we can do to be supporting of them. Our members come from many different cultures, and English is often not their first language. We hire staff that reflect the cultures of the members that we serve. Our staff are connected to help make our members, to connect our members to care coordination, customer service, finding a ride to a doctor, and also making sure that we're meeting the culturally specific needs of our members. This bill takes away the care coordination, funding flexibility, innovation, and local partnerships that our plans have built up over decades. These services simply cannot be replicated or rebuilt by the bill that is being proposed today. UCare wants to build on what is working, and what we will hope that you recognize the tremendous added benefit that Medicaid managed care provides to Minnesotans. I urge you to maintain and strengthen our current system, and I'd be happy to answer any questions.
Thank you. And now, members, do you have any questions or comments to the bill? Yes. Senator Abler.
And just a comment, driving in this morning, I was on a back road just a mile away from here and actually took a wrong turn, but there's a guy in the street actually clearing out part of the snow for his neighbors. In this, like the snowplow comes by, and here's this guy just like clearing out like 20 feet of snow row. So, Madam Chair, there is hope for mankind. There's people out there doing nice things. Madam, is this a serious proposal that you're actually going to think about, or should we waste any time? I have a lot of thoughts on the whole topic, but is this, you planning to put this somewhere, or is this a courtesy hearing, or what do you think?
Well, Senator Abler, we're planning to lay the bill over. I think if you want to ask the author more about that, I think that would be more appropriate.
All right, well,
So, Senator Marty, would you have a
is he
response?
online?
Yes, he is. He
All right,
is
well,
here.
I mean, if you're planning to, I'll ask my questions, and I assume it's a sincere effort,
Yes.
certainly on the part of the author, I know that, but, so personally, I'm not that impressed with the HMO system either. I think we've been asking for a long time about an audit to know, like, where does the money go? We provide money for a 5% raise on somebody, and we can't make them do that, which is totally bizarre to me. It's a creation of us. And when we ask questions, we get a lot of obfuscation, we get a lot of concerns about pre-authorizing. I'm in one of the plans, and I have to pre-authorize to get $2.38 to abide by my contract, and I cannot understand how that makes any sense. And so the bill I favored was a Senator Mann bill in mine that would give people a choice to choose, and which I think would create competition, and maybe they would quit doing more foolish things. Senator Marty, I know your sincerity on these topics, and so I wasn't questioning that. I'm just like, if it's going to do this or not. And it might save money, I don't know. But I just let's say we pass this bill, how on earth do you think DHS can handle 1.2 million enrollees when they have a hard time managing 100,000 people on waivers and changing from PCA to CFSS when they spent 12 years planning for it? So I guess that'll be my singular question, and then I'll let other people talk. So thank you, Senator.
Senator Marty.
Thank you, Madam Chair and Senator Abler. First of all, yes, as I talked with the chair about this ahead of time, the law the direction to the commissioner in 256.9631, the alternative care delivery models, that report's due out next year. And part of the reason for this hearing is so that I think this would be an appropriate one of those three models they're supposed to spell out. Part of the purpose is this, to bring it forward, because I am serious about pushing this. And I think as the chair and I discussed, action on this is likely to wait till next year, but bringing forward a specific plan and urging the DHS to look at this as one of their implementation models they present, I think would be very helpful. So in talking about this, requesting the hearing, we discussed laying it over and giving a push to DHS to study this. In terms of the concerns you mentioned about the health plans, and I think you've been also outspoken about concerns about it, I think the issue is who is best able to coordinate care? Who is best able to deliver care? We had a case where, as eyewitness testified about how health plan patients aren't able to use hospitals that they're supposed to be going to, that they're going to deliver at. They can't go prenatally or postpartum care there because the health plans fight with each other. 100% publicly funded program, and the patients aren't getting care because the health plans are having fights with each other. That kind of problem is huge. And in terms of that, I think Ms. Batalgan's description of how many patients came in because their managed care organization was encouraging to go in for a pap smear. She said in 30 years, I think she said she could count on one hand. And she says it's a daily occurrence where people from the clinic and others get people to come do this. It seems to me that when we look at our system, which is obviously, I think we all recognize, far and away the most expensive in the world, we have such poor level of care we're providing. To me, directly paying for people the way we do the rest of the economy makes a lot more sense. And the importance of this, the idea of having, I call care coordination, the American Cancer Society letter suggests we call it patient navigation. And I think we're all talking about the same thing there, and that is making sure the clinicians who are working with people can help them and have the time and the resources to do it. And simply taking off the burden of fighting for prior authorizations, fighting to make sure care is approved, medications are approved, everything. All the time, just taking that off and changing that to care coordination would help a lot. But then also this bill would have some of the savings would be going to actually a bump in pay for primary care clinics so that they could help coordinate their patients' care.
Senator Abler.
Thank you, and I appreciate that. And Senator Marty, you and I aren't that far apart on what we would like to see improve. And Senator Wiklund, I think we all want to get our money's worth. And I think, I defend the plans and I criticize the plans, and which is just like any good marriage, I guess. But I think we do need to know what we're getting for our money. I don't know if that's part of the plan, part of the study. Give us more money and trust us, we're going to take care of people, and our outcomes are lousy in the disparity populations with these very categories, and they say there's not enough money to pay providers well enough. How do we know that? You know, and well, I could go on at some length, but I think that this is the committee that has the experience compared, I mean, and I think the open-mindedness to actually get after some of that, particularly when we're facing an even deeper deficit probably tomorrow, and changes coming with the feds, like it or not. So thank you. I'll leave it at that.
Thank you. Senator Port.
Thank you, Madam Chair. Thank you, Senator Marty, for bringing this bill. I think it's an important part of the conversation that we start having. I guess, have a question about the oversight that exists. The testifier from UCARE mentioned that the Inspector Generals are an important part of oversight, but the Inspector General who oversees Health and Human Services was fired by Donald Trump and Elon Musk a few weeks ago, along with 16 other inspector generals. I think as we are losing federal oversight like that, it is more and more important for the state to step in and take an active role in understanding how, how care is managed, how folks are getting that care. Does that play into your thoughts about this bill, Senator Marty?
Yes,
Senator Marty.
and Madam Chair, Senator Port, yes, I think one of the things I'm scared silly about some of the changes at the federal level, both in the cuts in funding, which will shut down every rural hospital in the state if they do the serious things that they talked as if they might do. But the loss of the inspectors general and everything else, of course, we still have one in DHS. I think there are proposals to increase other stuff here. But one of the things I'll argue is that simplicity of the system matters in terms of where opportunities for fraud exist. When you're billing multiple parties and all the stuff going back and forth, who double pays. There was a firm that started up in Minnesota about 4 or 5 years ago now that said they would contract with employers for employee health care plans, said they would do nothing more than for a fee of $400 or $500 per employee per year. They would check over all the medical bills. And they said they could virtually guarantee they'd find more errors in billing than they could find in terms of that. And to me, when you are billing multiple people for the same thing and multiple whatever, people might be getting more of what they need or less of what they need. And the opportunities, even among legitimate providers trying to do the right thing, the opportunity for error is much more. And I think as we're looking at less money available, as we're looking at more need to be efficient with our own money and to prevent fraud, I think the simpler the system, the more accountable it is and the easier it is to catch that fraud.
Senator Port? No. Senator Utke.
Thank you, Madam Chair. And the concerns over something like this is a proposal run right through the roof for me. The fact that we would be growing DHS by another large amount as far as adding more duties to their plate. We've seen what the track record is the last few years. They got to get caught up with what they've currently got going on. That's a huge concern that we would expect them to do a whole lot more work. But the biggest thing as I look through this bill and you look at all the different things that it's requesting is the extreme cost. Does anybody have an idea of what we're looking at cost-wise on this bill?
Senator Marty.
Yeah, Madam Chair, Senator Utke, first of all, when we're looking at the costs, the things we're trying here, the grants to provide community health workers and to do outreach and stuff to help prevent rehospitalization of patients who have no support at home and they come out of the hospital and they get rehospitalized because they have no way to take care of themselves. All those costs, those grants in there are meant to come out of the surplus, the money we save from doing this. Connecticut, the one state that did real deprivatization of the insurance companies that were providing the care, saved significant money, and their cost curve was changed, and it went way down and become one of the more efficient systems in the country now. To me, we can save a lot of money with doing that, and just the scope of this. Again, I think a lot of you recognize that Medicaid is the biggest part of our state budget, the biggest single expenditure, and so the numbers are just phenomenal. Again, that one article, I only saw one article anywhere in the news media a couple of years ago talking about the health plan profit on our public programs was 2/3 of $1 billion. That's all Minnesota and federal dollars going into it, 2/3 of $1 billion just in the earnings that year, above all the administrative costs, above all the other stuff. And DHS has a huge administrative staff just to try and administer the contracts, and I'd argue that the money going out the door there is not well watched. One quick illustration, during the COVID years, I was on the panel, the legislative panel that was reviewing money going in and out during the crisis year of COVID. And one of the things that they reported was that there was actually a decline in healthcare use during the COVID thing because people were staying home and they were canceling routine appointments and so on. And so they said the Medicaid savings for the state, they reported Medicaid savings. I said, how much of that was in the managed care portion? How much was in the direct payment portion? They said, oh, that's only from the direct payment portion. Well, the vast majority of it is in managed care. How much is the savings from that be? Well, we won't know until next year, and the health plans will tell us how much we overpaid them. I mean, that's not an accountable system. And again, when there's 2/3 of $1 billion in one year, it was not a typical year. 2/3 of $1 billion in earnings, not the expenses or anything, on our public programs. This committee knows what $1 million can do for certain projects and so on, and we can't afford that. So I'd argue this is far more efficient.
Senator Radke.
Thank you, Madam Chair. And I guess we get to agree to disagree. And that's what's good about what we do here, because managed care organizations do so much more than just pay for the health care of the people they serve. It's the outreach. It's the other options of total personal care and such. And, you know, living in rural Minnesota, I see that firsthand. So that's the one thing when I see this come up and we're talking about grabbing onto savings. I don't believe there's a dollar to be saved because I think those dollars are all being well invested into the care of the people they serve. And so, you know, I heard what we said when we started, or what was said when we started, that this is going to be laid over and it's probably a conversation for next year, which is great because I think it needs a lot more conversation and a lot more debate on what's going to go on. So I won't go into a lot of the details because hoping that that's where it's going to end up because, you know, frankly, we know what's ahead of us. In 4 weeks, we hit first deadlines and we've got a budget to work on. So this we can put on the back burner and tackle another day. So thank you, Madam Chair.
Thank you. Senator Liskey.
Thank you, Madam Chair. Senator Marty, I know you and I have talked at length about different ideas on how to maybe solve the current healthcare situation that we're facing and the providers that are struggling with the current reimbursement rates, the different solutions that could be in place there. And, you know, when I saw this bill, I was hoping that we were moving towards a county-based plan situation. But then I got a chance to read through it a little more, and it seems that we're definitely putting a lot more pressure on DHS than I had originally expected. My goal here, I guess, and my question to you is, would this bill be more of a promotion towards those county-based plans, or are we actually, in the end of the day, going to end up leading towards them closing those plans down and everybody moving to the DHS plan?
Senator Marty.
Yeah, thank you, Senator Liskey. Yes, I strongly agree with you. The county-based plans are a gem, and this bill, there's a letter in the packets, I believe, from Steve Gottwald of the Minnesota county-based health plans, whatever they're called, talking about the importance of this because, yeah, the bill clearly says the model they are doing, as you said, makes good sense. Strong bipartisan support for the work they do, And the difference between them and the quote, managed care organizations is the counties, because they are the social service providers and everything else, they are responsible. If somebody doesn't get the care they need, in the end, they end up dealing with them in other crises centers and so on. And that's costing the counties so much money. And they've done an excellent job in the counties that have them, an excellent job of efficiently doing this. They provide better access. Some of the health plans, we have great networks, but if you've got a mental health issue, well, none of our doctors who we say are in the network, none of them are seeing new patients. The health county-based plans have been doing a remarkable job of engaging with them directly. And no, I strongly agree with you. This plan would explicitly calls out the county-based plans as the ones who administer it. It's in 33 counties now. They tend to be lower population counties, but I think we should be having more counties doing this, and I think this bill is a step forward. So I'll look forward to further discussions with you on that.
Senator Liskey, any further question?
Thank you, Madam Chair. I guess, Senator Marty, you and I are going to have to keep working on this. I do believe there are, the thing for me is you still want to offer the idea of choice to your patients and have your patients be able to make the choices for their health care. The concern, obviously, if we move to this model my concern is that currently, if we move to this model, is that we would lose most of those county plans because it becomes easier, less burden on the counties if they just shift to the DHS portion of this model. And so I just want to find a way maybe that we can make it so that it doesn't do that. Other than that, I appreciate the discussion, and I think we need to keep all plans and options open until we have a good understanding of what each motion will do. So thank you.
Madam Chair?
Senator Marty?
Yeah, one final comment on Senator Liskey's point. And yes, I think the county-based plans will continue to grow under this. They actually won't be having the fights they do. And the other point you mentioned about choice, to me, what patients want a choice of is which doctor, which hospital, which clinic, which provider they can use. Under our current system, you're fighting among plans and who's got what network and everything else. In the county plans, and this plan basically gives the patient the choice. Lets the patient and the doctor, the patient and the provider make the decisions. To me, it's the limited networks that are hurting people in that way and saving money. We're just spending all the more time of paperwork between each clinic and each health plan, each patient in each clinic and each health plan. We're spending all that paperwork and so on. What people want is a choice of which doctor they go to, which clinician they can see, which chiropractor they can see, dentist. That's what they want to have, and this bill gives them the choice of that. It doesn't give them a choice of which insurance company. It gives them a choice of who they see, and that's what I think is so important. And yes, I look forward to continuing the conversation and want to thank the chair for giving the chance to do this and hoping that DHS will include this in their models.
Thank you. Senator Curran, and just a gentle reminder, we have 2 more bills to take up today, and we'd like to get through. We have testifiers here, so Senator Curran.
Thank you, Madam Chair. Senator Marty, I think the conversation, and you just kind of highlighted it, it's really about what's the choice. It's really about care, access, and cost. And when we move to a government program, you really remove choice and appeal or any type of arbitration, because they really don't have a choice. And the thing that concerns me is, I think Senator Utke asked, what would this cost? This would grow Department of Human Services exponentially. I have real concerns based on their output. Every single element in our human services here depends on the state agency in coordination with the county to act or to operate at the highest level. And we don't see that. And so when we leave, essentially this would leave citizens with no choice. And you describe it as, well, they just have access to everything. But it's always going to be about managing what's that total cost, how do you provide access, and then how do you provide care within that model. And to say that government is going to be able to manage it far more effectively, I just don't see it today. We don't even have a workforce that gathers in a common place when the rest of the world is changing. And the difference is the incentives and the accountability within each of those business models. When government fails, or if DHS fails, they're just rewarded. They'll then come back to us and say, we need more money, we need more people, and we need more money for service, and we need more people. And the business model won't change. And so I love the conversation. We're all trying to solve the same thing. For me, it's about across all the services and where we require DHS to perform at the highest level. No one's willing to change how that business model operates so they understand, or we can bake in the things that don't occur naturally from an accountability perspective, because they just don't have it. It's not bad people, right? It's not it. But it's a business model where if they fail, they get paid, right? And unfortunately, too, if they do extraordinary work, we can't even reward them when they do extraordinary work. And I know there are many out there who do that. So from the model to just throw on more and more resources to them, I don't see it without any drastic change. And I haven't seen anybody interested in changing how our government units operate. And human services, to me, is one of the most critical because it really affects people's lives, right? And that's one why I'm here. So I don't know. I haven't heard anything. This bill isn't going to change how they operate. We got lots of issues like the county-based, or the county-based purchasing. All those things I think are great. How do we keep it in the community? Because it's always going to be the community that has the best access to resources or the needs, because they're unique and they change every 20 miles. But I don't hear anything, and so that's the piece I'd love to partner with you on, because it's impactful not only just for this bill, but from our nursing homes, our group homes, every aspect of the element of our care. Would love to partner with you because it has to happen no matter what we expect out of Department of Human Services or any of our government entities. We need more, and we need to bake in that accountability. None of this would do that to that agency relative to the managed care providers today. They have so many different checks and balances because they have a bottom line to meet. And so they do things differently than we do here. It's not about profit, it's not about loss, it's about the training models that we deploy. And that's what I'd love to work with you on. Someone to champion, walk alongside, because everything would get exponentially better. We need them to perform at a much higher level. So I hope this is laid over and we work on it next year or continue the conversation. Thank you, Madam Chair. And thank you, Senator Marty.
Madam Chair, just one closing comment. If there are no other comments, I'll just say quickly in closing that, frankly, this is not a government-run healthcare system. This should be a patient and provider, patient and nurse, patient and doctor-run healthcare system. I think that insurance companies, employers, and government are interfering way too much in that. The most simple, efficient way to do it, which Connecticut and others have showed, is that we just deliver it directly where the patients choose which clinics and hospitals and doctors they use. Anyhow, I think that any willing provider thing that I think Senator Abler and others have been pushing is exactly what we ought to be doing. This would make that happen. Anyway, I appreciate your time on this. I know you're busy, but I think this is important for preparation for next year, and I hope the DHS will take this as one of their proposed models.
Thank you, Senator Marty, and I do appreciate your bringing the bill forward. I think it is something that we need to have a lot more discussion about, and I do think that the study that we have in progress is, well, it is intended to help us get at some of the questions that we've heard raised about how much would this cost as compared to what we are spending today. I think we need to know that before we change to any new model. And I think the ability to look at alternatives was a goal of the study. And I think that this particular alternative to focus on, patient-centered care and making sure people have access to primary care is one that's definitely is worthy for exploration. So I appreciate your bringing the bill forward, and Senate File, Senate File 1059 is laid over. And
Thank you, Madam Chair, members of the committee.
Thank you. And now we will move to Senator Port, Senate File 1567. And members, we would like to get through, we have testifiers here for both of the remaining bills, and we need to be able to finish before 10:45. This bill, Senate File 1567, does need to be referred to the Commerce Committee. Senator Port.
Thank you, Madam Chair and members. Our healthcare system is broken. You can see it in the patient health outcomes that are far behind our peer nations. You can see it on GoFundMe, where the overwhelming majority asks for help paying for medical bills. And you can see it in the actions of health insurance companies who use AI algorithms to bulk deny claims with no justification. Instead of a health insurance system that helps patients stay healthy, we have companies that fleece consumers for all they're worth, create third-party companies to confuse patients, and delay or deny or refuse coverage. Research from the Kaiser Family Foundation research shows that the Affordable Care Act insurers denied 20% of all claims in 2023. Of those denials, just 6% were denied because the insurance saw a lack of medical necessity. The most common reason insurance gave for denials was other, 34%, followed by administrative reasons, 18%. Statistics like this are why everyone has a story about fighting with their insurance for the care that they need. And the remedies we have in Minnesota, the resources for patient support, are confusing and opaque. It can be especially difficult and necessary for people with chronic illnesses or complex medical needs whose claims are denied with no rhyme or reason, no explanation given. You can file an appeal, but let's look at the barriers to that process. First, you have to know you can appeal a denial and that it's worth your time. Around half of appeals are successful. Then you have to figure out what number to call or where to send a letter, find the time to coordinate with your doctor, figure out what words to use to be taken seriously, all while dealing with an illness. The Kaiser Family Foundation research again said consumers rarely appeal denied claims, fewer than 1%, because most don't understand the process. On top of that, an appeal can be like taking on a part-time job. If you're working long hours, have kids to care for or parents to look after, work a second job to keep up with your rent, you don't have the hours and hours every week to sit on hold with your insurance company or PBM and navigate dozens of hoops to jump through. And even if you do all that, follow all the right steps and do everything you're supposed to, you still might get told that you're not doing it right, like I was. This is a folder of the paperwork sent to me by my insurance company and PBM in response to one request for the documentation that was used to deny a treatment that my doctor prescribed for me. In August of 2024, my doctor at Mayo prescribed a treatment for me. The first appointment was scheduled for September 6th. The morning of September 6th, as my husband and I were on our way to Rochester, was when I finally got the call to say that the treatment was denied. I had called 7 times prior to that to ask for confirmation. I asked for the documentation that was used to deny, and they said that the information on how to get that would be in the denial letter that they sent, which I would receive within 10 business days. It took about that long, and in that letter, it says, if your healthcare provider would like to discuss this case with Magellan Physician Reviewer, or you'd like to obtain a copy of the criteria used to make the decision prior to initiating the formal appeal process, please call Magellan at this 800 number. So I did. They seemed to have no idea what I was talking about. I finally got to someone who said, oh, you just want the documentation used for the denial. I said, yes. They said, great, there's a form for that. I was like, okay. They were like, I'll mail you the form. I was like, can I just print it off somewhere? No, it's not available online anywhere. We have to mail it to you. So I said, okay. They mailed me the form. I got it again about 10 business days later, filled out the form, sent it back, nothing. No response, nothing. I called and they said, well, it can take up to 30 days, so why don't you wait 30 days and then call us back? So I called on the 30th day and they said, we don't have any record of that. We don't see anything like that in our system. We can send you the form again, So they sent me the form again, which took another week, and I filled it out again, this time sending it back certified mail. I have confirmation that they received it. They say they have no idea. They don't have anything like that. No idea. So I asked to speak with a supervisor. Can someone just send me the documentation you used? The problem with long COVID is that most treatments are not FDA approved yet because it takes time to go through that process, and it's a new illness. So there are reasons, it's necessary for doctors to know the reasons that a patient is denied in order to properly appeal it. My doctor didn't want to appeal without understanding why it had been denied. We did this 5 times. It took me 5 months to get a response. And that response only came after I finally found a place on the Commerce Department website where I could file a complaint, which they responded to, again, said it could take up to 30 days. They did get a response from the PBM who said, of course, we'll send that right out. You know what they sent me? The same letter that they'd sent me 5 times before that said nothing about why it was denied. I called back Commerce, and they finally, after almost 6 months, sent me a 2-page letter with 3 lines that explain why it was denied, which I will say it is not medically necessary. How my doctor is supposed to use that to file an appeal, we're not sure. We're still trying. It has now been like 8 months since my doctor prescribed a treatment that she believes will help my day-to-day life, and I still cannot get an answer on if that will be covered or not. I wish my story was unique, but it's not. It is unbelievably common, and that's why it's important that we pass this bill. As it stands, Minnesota's jurisdiction of health insurance complaints is disparate and confusing. The Department of Commerce and DHS split jurisdiction of health insurance complaints depending on what type of insurance you have. MDH handles HMOs and the No Surprises Act. Senior Linkage helps seniors with Medicare. The AG's office handles consumer complaints, and on and on and on. The Office of Patient Protection would bring together this scattered oversight and be a one-stop shop for Minnesotans struggling to get coverage and help them fight back so that they get the insurance that they're paying for. The office would help Minnesotans navigate their labyrinth of insurance coverage, support patients contesting denials, and collect data for the legislature to guide future policy. We are not alone in this. Connecticut established its office of the healthcare advocate in 2005, and Wisconsin's Governor Evers proposed a similar office just this year. The Office of Patient Protection's bird-eye view would give the high-level view needed to identify systemic problems in our state's healthcare system. We may not be able to reform U.S. healthcare systems in our lifetime. I hope we can, but we can help people find their way through the maze to the coverage and care that they deserve.
Thank you. We have 3 testifiers online. First, Tricia Harms. If you could please state your name for the record and begin. And I would ask that all testifiers, if you could keep your testimony to approximately 2 minutes, 2 to 3 minutes, because we are going to be running short on time. Ms. Harms.
Hi, good morning, Madam Chair and members of the committee. My name is Tricia Harms. I am here today to urge you to support Senate File 1567, not just as a concerned citizen, but as a daughter fighting for my mother's life. My mom, Sheila, is 61 years old. She has type 1 diabetes, an autoimmune disorder, and psoriatic arthritis, a combination of conditions that make daily life a constant battle and require serious medications to keep her safe and alive. She wanted to be here today to tell you herself why this bill matters, but instead, she is driving to FedEx in this weather because she is required to sign in person for her $16,000 psoriatic arthritis medication. That is not an exaggeration. This cumbersome process is just one example of the many challenges she faces in managing her health. My mom needs insulin pods for her type 1 diabetes. However, her insurance company only covers one brand of pods and rations how many she can have at a time. Recently, my mom had a batch of defective pods, a life-threatening situation. But instead of getting quick replacements, she was met with insurance red tape that left her stranded without the medicine she needed. My mom went into ketoacidosis, which is a terrifying condition that can result in organ failure, coma, or death if it's not treated immediately. If you know anything about diabetes and ketoacidosis, you know that every second counts. There's a point where you just don't come back from it. My mom was rushed to the emergency department and was teetering on the brink of death in the waiting room. By sheer luck, an on-call nurse in the ER recognized her from the diabetes clinic and acted immediately, intervening in the final critical moments to save her life. This was completely preventable, but because of her insurance restrictions and bureaucratic obstacles, my mom nearly lost her life, and I nearly lost my mom. That is why I'm here today, because no one should have to fight for their life against a cruel and broken system. People like my mom deserve protections and access to the life-saving medications they need. Establishing an Office of Patient Protection is a critical life-saving step in ensuring that no one else has to suffer the way my mom has. Sheila and I urge you to support this bill. Thank you for your consideration.
Thank you. Next, we have Lena Gardner. If you can please state your name for the record and begin your testimony. And she may not be on the Zoom. And then do we have Dr. Bridget Keller?
Yes.
Welcome to the committee, and please state your name for the record and begin.
Thank you, Madam Chair and members of the committee. My name is Dr. Bridget Keller, and I'm a parent and a physician in the Twin Cities, and I strongly support creating an Office of Patient Protection. As a physician, it's clear to me that one of the greatest barriers preventing people from getting the care they need is a health insurance company refusing to authorize or pay for care. Care delays and denials by insurance companies hurt patients, blocks medically necessary care, and contributes to physician burnout. There is no transparency or accountability when insurance companies routinely make doctors and patients jump through hoops to get care authorized, deny claims, or force patients or providers to pay for medically necessary care that they should have covered. When this happens, there is no place for people to go to for help. The appeal process is consuming, confusing, time-consuming, and isolating. I have experienced this frustration myself, personally as a physician and as a parent advocating for my child. My daughter has a mental health disability. For the past 10 years, I have been struggling to get her needed care due to insurance company denials. Recently, I had to submit multiple appeals to request continued treatment care coverage. But despite the recommendations of the entire psychiatric treatment team, the insurance company denied coverage, and she was forced to leave a program where she was finally making progress. And we were forced to pay out-of-pocket costs while waiting on that appeal. Like Senator Port described in her statements, the appeals process was cumbersome and challenging, despite my knowledge of the system as a physician. Can you imagine how difficult it is for someone without this knowledge or someone who doesn't have access to internet or speaks English? Establishing an Office of Patient Protection is an important step to improve transparency, support patients, and make sure the insurance that people are paying for covers the care that they need. Thank you for considering this bill. I urge your support for patients and for providers.
Thank you very much for your testimony. Members, do you have questions? Senator Abler.
Well, thanks, Senator Port. I'm sorry we need something like this. Actually, we do. I mean, this is kind of a sketch of an idea that I think actually should go forward. We have, I've been in practice 46 years. When I first started, people didn't talk about money. The clinic down the road started asking for people to pay, asked about money, and then people were appalled in Anoka that was, how could they, what? Because people, it was $800, 80/20, and people were connected and they paid their bills, and it was a different time. But it's evolved to the point that if you don't have a card, I tried to make an appointment at a dermatologist driving in. Well, just kind of schedule, well, I need your information. Like, I can't make an appointment. So I'm like, well, I'm driving, I can't give it to you. We've gone to that point. We've gone to the point that the people that we spend all this billions of dollars to become the gatekeeper, and you have some 25-year-old, not even an MBA person, deciding what you need based upon a rubric or an algorithm, or just that they don't feel like paying right now. And it is intolerable. And so you're a pretty astute person, and so your story is an exemplar, but there are far too many. So I'd like to sign on your bill, but just going forward, I suggest that you work on the order of what the governor tried to do with this fraud thing, which I'm not sure if that's an effective thing that he came up with, but the same idea. There's 3 agencies tasked with overseeing HMOs and the insurance companies in the state: Commerce, Health, and DHS. And I would suggest that for probably very small money, we could consolidate their efforts. They could still sit in the same offices, but there'd be a focused effort, somewhere to call, a consumer line of some sort. What you've got designed here is kind of an ombudsman. And for all their credit, they're not doing very well helping the people that do what ombudsmen are supposed to help. There's just too much demand, not enough staff, and anyway, but I think that I'm willing to help you with that idea and argue for it, and I think the health plans would want to do that as well. They should help us design this so they can find out, because I know the lobbyists sitting here don't hope that you would never get your question answered. I don't think they would hope that people would not get the service. That's what they intend, because there is a good face and a good heart to these companies. But what happens then operationally is you get somebody way down the line, and there is somebody somewhere who says, we're not paying that, and we're going to delay, and we're going to make me pre-authorize $2.38, so I'm just not going to do it. So they save $2. There's $2 they just saved, like, yay. Yeah. So let's get something done with this, and thank you for bringing this forward.
Thank you. Senator Bolden.
Thank you, Madam Chair. Thank you, Senator Port, for bringing this bill. I am very, very grateful for your work on this. It is so necessary. Thank you for sharing your story. And as you said, it is not unique. We could have a conversation all day about the stories of just the people in this room. And I think between the two of you, we could speak for many hours of the stories between just you and I. I am the point person for care for both my mother, who is on Medicare and has multiple, health complications and chronic issues, and my son, who is on Medicaid and Medicare and has multiple chronic complicated medical issues. And I think every day about all the resources that I have. English is my first language. I've worked in the healthcare system for over 20 years. I have many contacts and resources, all of the resources at my disposal that basically anybody could ask for. And navigating the system is nearly impossible for me. And so what does that look like for anybody else is absolutely impossible. So just thank you for this. And I appreciate Senator Abler's comments about, no maybe one individual person, wants this to be the impact. And that's why this is so necessary, because it is the system. This is a systemic problem. The system is built to deny people care. I mean, the statistics you gave about the number of denials is egregious. And so we do need a systemic approach for this to be looking out for patients and, navigating, for anybody with a chronic health condition or just, navigating the system at all, it can feel like a full-time job. And just the challenges and the complexity and the difficulty of it, I cannot tell you how many hours a week I spend on the phone navigating, coordinating appointments, trying to figure out denials. I have the form to appeal denials of claims saved on my desktop on my computer because I just know that I'm going to need it, and I have, navigated it enough that I sort of know the process. It shouldn't be that way. It shouldn't take such an effort to get people the care that their providers are saying they need. In many cases, care that people need just to live. It is, our system is cruel and harmful, and this is absolutely necessary to be sure that we are looking at that and doing it differently. People deserve that. Minnesotans deserve that. We all deserve that. So thank you for this bill.
Any other member questions or comments? Senator Port, thank you for bringing this forward. I think that Senator Dizik had a passion for trying to address this issue, and we worked with her on a bill, last couple years, and so I really appreciate your continuing to bring this forward. It's really important that we have, some plan or some method to help people address the system, and in the short term, we hope that we can work to improve the system in a systemic way to be better, but I think your bill is really important to try and start to work on that and give people some opportunities that aren't in place, and it's more challenging than it really should be. So, Senator Port, any final thoughts?
Thank you, Madam Chair. Thank you, members. Senator Abler, I will get you added to the bill. This is built off of a framework that Senator Dietzick started. And I think the fact that we spent a lot of time, she and I, over the last year or so, texting back and forth about the denial process and what that looked like and what that felt like. Because it is a ton of time. I spent well over 60 hours on the phone just for this one piece of my care. And it's very isolating. And so having one place for Minnesotans to go who can help them navigate through that. I agree with you, Senator Abler. I think my hope would be eventually that this would be the place where all of that sort of oversight would be able to be, the complaint processes for all three agencies would be able to come under this. I think there are creative and unique things that are happening around the country that we could build this into. I know we're in a place with a tighter budget this year, but I hope that this is something that we can think about starting in a small way so that it can grow into something that Minnesotans really could really benefit from. Thank you, Madam Chair.
Thank you. And as I mentioned, this bill needs to be referred to the Commerce Committee. So Senator Port's motion is to recommend that Senate File 1567 be recommended to pass and be referred to the Committee on Commerce and Consumer Protection. All those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and Senate File 1567 is passed and referred to the Committee on Commerce. And now we will move quickly to Senate File 2043.
Senator Wiklund, to your bill.
Thank you, Madam Chair. I do have, I have an author's amendment for this bill. If I could move the A1 amendment.
Senator Wiklund moves the A1 amendment, which is an author's amendment. All those in favor say aye. Aye. All those opposed say nay. The amendment is adopted. Senator Wiklund.
Thank you, Madam Chair. Minnesota's healthcare interpreting community plays a vital role in bridging language barriers between healthcare providers and patients. The services interpreters provide to facilitate communication between healthcare providers and limited English proficient patients are essential to providing the best possible quality of care. We also know that there are significant challenges that exist in both providing and accessing interpreter services. This includes accessibility barriers, especially in rural areas, and the significant workforce challenges they are experiencing as we hear of a decrease in new interpreters entering the field. Healthcare interpreting needs are changing, and addressing these changing needs and solving the challenges I mentioned requires deep community collaboration and expertise from the Minnesota healthcare interpreting profession. The bill before you today aims to do just that. Senate File 2043 creates a healthcare interpreter services work group that will be tasked with providing recommendations to the legislature that support and improve access to the critical interpreting services provided across the state. The work group will address challenges with spoken language interpreting, including requirements for registered and certified interpreters, researching barriers to access, addressing reimbursement, training, and certification. This important work will help direct the actions needed to increase access to quality interpreter services for patients. It will help improve healthcare outcomes and decrease health disparities, and address healthcare interpreting workforce shortages. The bill was drafted through a collaborative approach, including input from interpreters, educators, state agencies, health systems, health plans, professional associations, and others. It's evident that accurate and effective communication between patients and healthcare providers is critical to the quality of care Minnesotans receive and the healthcare outcomes they experience. It can be a matter of life and death if people are not receiving quality healthcare or have access to quality healthcare interpreting. I do have some testifiers here today, and they can speak to the need for this work group approach.
Thank you, Senator Wiklund. We'll first hear from Rosa Tak, and next from Dr. Vang. Ms. Tak, welcome to the committee. As you are ready, you can introduce yourself and proceed.
Good morning, Madam Chair and members of the committee. For the record, my name is Rosa Tak. I am the Executive Director of the Minnesota Council on Latino Affairs, one of the 3 ethnic councils for the state of Minnesota. The council is tasked to advise and inform the state legislature on the pressing issues facing Latino Minnesotans. We now account for 6.4% of the state population, or 367,000 people living in every district in Minnesota, all of us contributing to making the state stronger. I am testifying in support of Senate File 2043. This issue is not only personal, but it also reflects the priorities of our communities. I speak 4 languages, and I am lucky enough to navigate the healthcare system, however imperfectly, because after all, who doesn't, as we just heard the stories in the previous bill. Luckily, I can access healthcare without the need for interpretation. But unfortunately, not all the people our council represents have the same possibility. The healthcare language, as we all heard this morning, just recently, it is very complicated and difficult to manage and understand, as Senator Port illustrated with her own story and the stories that we heard previously. Except for medical providers and health insurers, this language can even feel foreign for native English speakers. So imagine how difficult going to the doctor or to a clinic or to manage these cases can be for immigrants and refugees coming from as far as South Asia, Central Africa, the Middle East, or South America. For decades, our council has heard stories from providers or community members telling us about children or uncertified individuals interpreting for parents, either at school or clinics. The need for professional and high-skilled interpreters will continue to be needed. We are so grateful that Senator Wiklund continues to be a champion for language access and health care, and that she sees the intersection between language access and reducing these health disparities, and driving down the costs and inefficiencies in the healthcare industry. It's also encouraging to note that Representative Nadeau will be the chief author in the House, making it a bipartisan bill. For almost a decade, the Council has been a strong supporter of increasing access to quality interpreter services for patients in the form of assuring training and certification requirements for people choosing this profession, closing gaps in services in rural areas, and making interpreting, training, and education funding available. This will result in optimal communication, patient satisfaction, and provide incentives to reduce the shortages of qualified interpreters in the state. This bill is extremely important. It considers, as Senator Wiklund explained, establishing a working group with a variety of stakeholders with expertise in the field to assess the current challenges as needs change across the state and to break through various barriers that need to be addressed to ensure access to quality health care for everyone. This work group will help create a much-needed space for the healthcare interpreting profession to collaborate on solutions, making sure that patients with limited English proficiency have access to trained professional interpreters. Let's make sure that this bill that is good for patients, for public health, and good for the bottom line becomes a reality. It is overdue. When people can communicate effectively with healthcare providers, health outcomes are also stronger and come at a lower cost. Thank you for your consideration and voting in favor of this bill, and I'll be happy to respond to any of your questions. Gracias.
Thank you for your testimony. Next, Dr. Vang. Please introduce yourself and proceed.
Thank you, Madam Chair, members of the committee. Thank you for the opportunity to testify in support of SF 2043. My name is Dr. Tali Vang, and I serve as the Vice President of Health Equity at Hennepin Healthcare. As a clinical psychologist and health equity leader, I have seen firsthand how access to high-quality interpreter services directly impacts patient outcomes and helps address health disparities. Imagine being in a medical crisis, confused, afraid, and unable to understand your doctor. For many patients with limited English proficiency, this is their reality. Without professional interpreters, critical medical decisions can be compromised and also may lead to misdiagnoses, improper treatment, and avoidable harm. I recall working with a Hmong-speaking patient who had experienced PTSD symptoms due to sexual assault. She confided in me that she almost discontinued therapy after her first session, not because of the psychologist, but because of the interpreter. Although the interpreter spoke Hmong, they lacked the appropriate medical and cultural training to navigate sensitive topics with care. Instead, they used vulgar, abrasive, and shame-inducing language that made the patient feel deeply uncomfortable. For a Hmong survivor of trauma, seeking mental health support is already a monumental step due to stigma, cultural barriers, and fear. But when faced with untrained interpreters who use inappropriate medical terminology, the experience became re-traumatizing for my patient. This is the reality, again, for many LEP or language limited in English patients here. Not just in mental health, but across all areas of healthcare. Medically trained interpreters understand that certain words and phrases carry deep cultural and emotional weight. So for example, private body parts, like breasts and genitals, these are considered taboo topics and require indirect or metaphorical language to be discussed appropriately. Health conditions like epilepsy or sexually transmitted infections are often highly stigmatized, and if communicated bluntly, can reinforce shame and prevent patients from seeking care. A trained medical interpreter would know how to navigate these sensitivities using culturally appropriate terminology while ensuring accurate, respectful, and effective communication. This difference is not just about language, it is about patient dignity, trust, and access to equitable care. This is why SF 2043 is essential. Research consistently shows that patients who receive professional interpretation experience fewer medical errors, higher satisfaction, and better health outcomes. Yet barriers such as workforce shortages, lack of standardized training, and inadequate reimbursement continue to limit access to these critical services, especially in rural communities. By creating a spoken language health care interpreter work group, this bill takes a vital step toward improving language access statewide. It will ensure interpreters are properly trained to handle complex medical and cultural nuances, close health equity or health disparities, especially in rural areas, and support reimbursement structures that sustain high-quality professional interpreting services. By investing in trained interpreters, we can improve patient safety, enhance provider communication, and reduce health disparities for Minnesotans. I urge you to support SF 2043 and take action to ensure that all Minnesotans, regardless of the language they speak, receive the equitable, high-quality health care they deserve. Thank you.
Thank you for your testimony. Our last testifier will be via Zoom, Yvonne Arezia. Please unmute yourself and introduce yourself and proceed.
Thank you, Madam Chair and members of the committee. Good morning. Thank you for the opportunity testifying in support of SF 2043. My name is Yvonne Araiza. I am a healthcare interpreter and president of the Upper Midwest Translators and Interpreters Association. We are a chapter of the ATA. AMSHA promotes standards of quality for professionals, ensuring positive impact for the communities we serve. We aim to elevate the profession by providing professional development, advocating for the needs of our members, and encouraging talented professionals to join our ranks. AMSHA helped create the spoken language healthcare interpreter roster. The last time deep community engagement around interpreter services was conducted and reported to the legislature was in 2015, over a decade ago, by MDH. Yet the demand for trained professional interpreters has only grown. Minnesota currently lacks minimum educational requirements for spoken language interpreters in healthcare. Unlike other healthcare professionals, interpreters are not currently required to meet standardized educational or training benchmarks before working in medical settings. As a result, healthcare providers have no way of assessing the interpreter's qualification. This may create inconsistent language access services across different facilities. Educated, trained professional interpreters' knowledge and competencies is not recognized, and there's the lack of clear path to build their career with the absence of clear educational standards. Other states have successfully established minimum educational requirements for interpreters, ensuring greater patient safety, provider confidence, and professional integrity. It is time for Minnesota to start a collaborative conversation around the needs for patients in our state. This work group creates a much needed space for this conversation. SF 2043 will create a spoken language healthcare interpreters work group tasked with assessing the needs for minimum educational requirements for interpreters in healthcare settings, develop recommendations for interpreter training, competencies assessment, and workforce development, ensuring all patients have access to properly trained interpreters regardless of the language or location. By convening interpreters, healthcare professional, policymakers, and industry experts, this work group will provide evidence-based recommendations to help Minnesotans adopt a realistic and effective educational standards for healthcare interpreters. Supporting this bill will help improve patient safety, give healthcare providers the confidence that they are working with qualified language professionals, establish a pathway to professional development, strengthening the interpreting workforce, creating consistency across the healthcare system, and ensuring that all LEP patients receive high-quality language access service. In conclusion, I strongly encourage the committee to support SF 2043. Minnesota cannot afford to delay taking action to improve accessing and providing quality healthcare interpreting services across the state. Establishing a spoken language healthcare interpreters work group is the necessary first step to ensuring that all patients regarding of the language they speak receive safe, effective, and equitable healthcare. Thank you for your time and commitment on this issue, and I welcome any questions.
Thank you for your testimony. Members, any questions or comments? Senator Abler.
I know we're almost out of time, but so this is a really important topic. I recall when I was in the House, Representative Liebling had a hearing and people were yelling at each other. This was very contentious about licensing, credentialing, and all that. It was memorable. We need to sort this out, and if this is a way to do it, I just suggest that as you go into this, if you're going to really do it, the Department of Health should really be doing this anyway with their current staff. It's been a long-standing problem, and so they shouldn't charge you very much, maybe the hard costs, but no staff costs. But I would suggest you have clear goals for what you want them to come out with. What you have here, they're fine, but you really need to know what it is you want to get out of it and what guidance, because you want this to work, and you're not going to do this again, because it's going to be really hard to get consensus about how do you credential and how do you pay, and can they do it online? Can you have a 10-minute chat with somebody? And I wish you well in that, so thank you.
All right, I will just say, Madam Chair, thank you for bringing this bill. As I take care of patients in the hospital, many who don't speak English, having a skilled medical interpreter is critical in being able to build that therapeutic relationship and deliver quality care that meets the needs of patients. So thank you. Any final words before we take a vote?
Thank you, Madam Chair. And yes, Senator Abler, I worked on it in the Senate about 10 years ago, and we came a long way, and we had what I thought was a good bill, but it is challenging, and I hope that through the working group that we can come up with recommendations that are supported by all of the stakeholders involved, that they will, there is a requirement for gathering public input, and that's hopefully a rigorous part of it, because we want to make sure that people know about this and know that they can contribute. So I hope that this is a framework that can lead to some recommendations that we could move forward in a concrete way, because it's, to me, is really essential that we do some firm work to establish standards and, broaden the ability for interpreters to have a career path too. So thank you.
All right, Senator Wiklund moves that Senate File 2043 as amended be recommended to pass and re-referred to the Committee on State and Local Government. All those in favor say aye. Aye. All those opposed say nay. Motion passes, and the bill is on its way. There being no further business before us, this committee is adjourned.
Thank you.